A short course on physical therapy rehabilitation in burn patients. Let's start with the basics. Types of burn injuries. Burn injuries can be divided into first, second, third and fourth degree. Superficial or first degree burn. It is caused by sun exposure, low viscosity, and short exposure with hot liquids. It involves only epidermis. Its appearance is pink red, moist and no blisters. Moderate to severe pain occurs in superficial burns. Its healing time is almost 3 to 7 days. Superficial partial or second to 8 degree burn. It is caused by hot liquids and with acid or alkali chemical burns. It involves only superficial papillary epidermis. Its appearance is red, moist, blisters, intact epidermal appendages, and blanches to pressure. Severe pain occurs in superficial partial burns. Its healing time is 1 to 3 weeks. Long-term pigment changes may occur. Deep partial or second to 8 degree burn. It is caused by flame, electrical, or high viscosity, hot liquids. It involves deep layer reticular dermis. Its appearance is dry, white, non-blanching, and loss of all epidermal appendages. Minimal pain occurs in deep partial burns. Its healing time is 3 to 6 weeks, with scars. Deep or third degree burn. It is caused by flame, electrical source, or blast. It involves full thickness of skin and up to the subcutaneous fat. Its appearance is leathery, dry, white or red, with thrombosed vessel. In this type of burn, no pain occurs in the zone of coagulation, but it is painful at surrounding tissue. For its healing, skin grafting is required. Fourth degree burn. It is caused by prolonged exposure to flame, electrical source, or blast. It extends through skin, subcutaneous fat, and into underlying muscle and bone. Its appearance is black and dry. No pain occurs in the zone of coagulation, but painful at surrounding tissue. It requires excision. Burn first aid. How to manage minor burns. Following things should be remembered. Hold the burned area under cool, not cold running water, or apply a cool, wet compress until the pain eases. Remove rings or other tight items from the burned area. Try to do this quickly and gently before the area swells. Don't break blisters. Fluid-filled blisters protect against infection. If a blister breaks, clean the area with water. Once a burn is completely cooled, apply a lotion, such as one that contains aloe vera or a moisturizer. This helps to prevent drying and provides relief. Cover the burn with a sterile gauze bandage, not with fluffy cotton. Wrap it loosely to avoid putting pressure on burned skin. Bandaging keeps air off the area, reduces pain, and protects blistered skin. If needed, taken over-the-counter pain reliever, such as ibuprofen, naproxen sodium, or acetaminophen. How to manage major burns. Try to protect the person's contact with the source of the burn. For electrical burns, make sure that the power source is off before you approach the burned person. If needed, begin rescue breathing if you know how to do CPR. Remove jewelry, belts, and other restrictive items, especially from around burned areas and the neck, because burned areas swell rapidly. Cover the area of the burn. Use a cool, moist bandage or clean cloth. Don't immerse large severe burns in water. Doing so could cause a serious loss of body heat, hypothermia. Raise the burn area above heart level, if possible. Watch for signs of shock. Signs and symptoms of shock include fainting, pale complexion, or breathing in a notably shallow fashion. Complications of healing in burn patient. Following complications can occur in burn patients. Intrinsic minus. Edema in the hand results in the position of intrinsic minus. Wrist flexion, metacarpophalangeal extension, proximal and distal interphalangeal flexion. Hypertrophic scars. Shapes and sizes depend on location, on the body, and nature of injury. Edges are raised and end abruptly. Initially, may be red or pink in color. May exceed the limits of the original injury, keloid scars. Other complications include shock. Shock is a life-threatening condition that occurs when there is an insufficient supply of oxygen to the body. Signs and symptoms of shock include a pale face, cold or clammy skin, a rapid pulse, fast, shallow breathing, yawning, and unconsciousness. Heat exhaustion and heat stroke. They are often caused by being exposed to too much sunlight or heat. Symptoms of heat exhaustion and heat stroke include extreme tiredness and lack of energy, dizziness or fainting, feeling sick or vomiting, rapid pulse, headache, muscle pain, irritability, and confusion. Infection. Signs of sepsis and toxic shock syndrome include a high temperature, dizziness, and vomiting. Physical therapy assessment of the burn patient. The aims of the physical therapy is to prevent respiratory complications, control edema, maintain joint range of motion, maintain strength, and prevent excessive scarring. Assessment of total body surface area involved. The rule of 9 is used to assess the total body surface area. Head and neck 9%, trunk front plus back 36%, upper limbs 18%, genitalia 1%, and lower limbs 36%. When calculating burn size area, edema should not be included. A burn of greater than 20 to 25% total body surface area creates a global or systemic inflammatory reaction affecting all body organs and indicates a significant risk for the respiratory system. Burn type and depth. The depth of burn determines the potential for successful wound healing and will therefore help guide the initial treatment regime. Speed of capillary refill is a good indicator of burn depth. But it is rare that a burn will present with a single depth. History of presenting complaint. Check whether adequate first aid was given, if not, suspect deeper burn injury. Check whether there is any indication that the patient fell, it will indicate possible head injury, sprains, or fractures. In electrical injury, how much voltage involved? Which parts of body was in contact with earth? Suspect nerve and deep muscle injury with high voltage current. In explosions, falls, and high velocity injuries, possible tympanic membrane injury, loss of hearing, and difficulty communicating may occur. Ask about medical and surgical history. Ask about past medical or drug history. Check about pain medications, debridement, escharectomy, flaps or grafts, psychosocial status, self-image, coping style, mental health, and emotional behavior. Pain Intensity Assessment (FLACC scale). It is used to assess pain for children between the ages of 2 months and 7 years, or individuals that are unable to communicate their pain. Faces Pain Rating Scale. The Wong-Baker Faces Pain Rating Scale can be used in children aged 5 years and older. Visual Analog Scale. It can be used in children aged 12 years and older adults. Inhalation Assessment. Physical signs to observe. Hoarse vocal quality, edema, erythema, soot-stained sputum, stridor, inspiratory, and end expiratory crackles, on auscultation, and chest X-ray changes. Edema Assessment. Clinical stages and appearance of edema. Stage 1. Soft, may pit on pressure. Stage 2. Firm, rubbery, non-pitting. Stage 3. Hard, fibrosed. Mobility Assessment. Limb and trunk mobility. Assessment of limbs and trunk should include joint range of motion and strength. Limiting factors may include pain, muscle length, transarticular burns, scar contracture, and the individual specificity of the burn. General functional mobility. Factors to consideration when assessing mobility. Posture, demands of vocational roles, and ADLs, cardiovascular response to mobilization, neurological status, pain, concomitant injuries, and weight-bearing status. Burn Outcome Measure. Burn-specific health scale. It is widely used within the area of burn to examine the physical and psychosocial functioning of burn patients and their quality of life. Role of the physiotherapist in the rehabilitation of acute burn patient. Depending on the size and the severity of the injury, this stage may last from a few days to a few months. Aims of treatment include reduce risk of complications, reduce edema, particularly where it poses a risk for impinging on peripheral circulation, or airways, and predisposition to contractures. Prevent deformities and loss of range. Protect or promote healing. Common treatment techniques include immobilization, including bed rest and splinting. Positioning. Recommended positioning according to area of burn. If the burn is on anterior neck, recommended position is neck in extension. If head needs to be raised, do not use pillows. If the burn is on posterior neck, recommended position is head in flexion, sitting or lying with a pillow behind the head. If burn on axilla, lying or sitting with arms abducted. Slings, pillows, figure of 8 bandage around chest for stretch. Prone lying. Anterior elbow burns. Recommended position is elbow in extension. Burn at groin region. Prone lying, legs extended, no pillow under knees in supine, limit sitting and side lying. Burn at the back of knee. Long sitting or supine lying, no pillow beneath knees. Burn on feet. Aim to maintain 90 degrees at ankle, pillow in bed, sitting with feet on floor. Burn on face. Regular change of expression. Soft rolls may be inserted into the mouth. Mobilization of patient. Burn patients should be mobilized as early as possible to avoid deconditioning and possible respiratory complications associated with prolonged bed rest. Active range of motion. Gentle active range of motion exercises is the preferred treatment during the acute stage of injury, as it is the most effective means of reducing edema by means of active muscle contraction. Passive range of motion. Passive range of motion exercises in the acute stage are contraindicated, as applying passive stretching forces may result in future damage to the burnt structures. However, passive range of motion can be applied to proximal or distal joints of burned area without stretching the involved structures. Management of edema. Elevation. Elevation of the hand above heart level is the most simple and effective ways to prevent and decrease edema. A Bradford sling can be used to facilitate elevation. Coban. Coban wrap can be used to decrease hand edema. The main advantage of Coban wrap is that it does not stick to underlying tissue, making it suitable for use in the acute stages of burns. Edema glove or digi sleeve. These are hand-specific edema management products. Role of the physiotherapist in the rehabilitation of subacute burn patient. Aims of physiotherapy in subacute stage are: optimize scar appearance, limit effects of scar contraction or prolonged positioning on range of motion and function. Address effects of prolonged bed rest. Common modalities include mobilization, both mobility and specific joint mobilization. Scar management, adjuncts to pressure garments, silicone, massage. Continuation of edema and positioning management where necessary. Passive joint mobilization. Passive joint mobilizations can begin during the scar maturation phase, once the scar tissue has adequate tensile strength to tolerate friction caused by mobilization techniques. Frequency and duration recommendations. Physiotherapy interventions should be applied twice daily, with patients prescribed frequent active exercises in between sessions. For the sedated patients, gentle passive range of motion exercises should be done 3 times a day, once indicated. Splinting. Splinting is of 2 types: static splinting and dynamic splinting. Static splinting include serial static splint and static progressive splint. Serial static splint. It is a device with no moving parts. It is designed to be remolded as a contracture improves. The most common serial static splint is thermoplastic palmar splint, molded in the position of safe immobilization. Static progressive splint. It is a device designed to stretch contractures through the application of incrementally adjusted static force to promote lengthening of contracted tissue. There are various types of static progressive splints available, depending on the area affected. One such static progressive splint is a finger flexion strap splint. This type of splint is used in the treatment of metacarpophalangeal extension contractures. Dynamic splinting. A dynamic splint is one which aids in initiating and performing movements by controlling the plane and range of motion of the injured part. It applies a mobile force in one direction while allowing active motion in the opposite direction. This mobile force is usually applied with rubber bands, elastics and springs. Dynamic extension splints. These are most commonly used in the treatment of palmar or finger burns. For example, in flexion contractures. All the finger joints including the MCP, PIP, and DIP joints are in full extension. Dynamic flexion splints. These are used in the treatment of dorsal hand burns. Splinting precautions. Splints need to be cleaned regularly to prevent colonization by microbes, which may lead to wound infection. Unnecessary use of splinting may cause venous and lymphatic stasis, which may result in increase in edema. Precaution must be taken to ensure that splints do not produce friction, causing unnecessary trauma to the soft tissues. Precaution must be taken to ensure that splints do not produce excessive pressure. There is particular risk of pressure injury to skin after burn injuries due to potential skin anesthesia. Immobilization of the hand to prevent deformity. The most common deformity associated with burns is the claw deformity. This position is also referred to as the intrinsic minus position. Position of safe immobilization. The position of safe immobilization of the burned hand is essentially the opposite of the claw deformity position. This position involves 20 to 30 degree wrist extension, 80 to 90 degrees flexion at MCP joints, full extension at PIP and DIP joints, and palmar abduction of the thumb. Scar management. Abnormal scarring is the most common complication of burn injuries, with the estimated prevalence of greater than 70% of those who suffer burn injuries. Scar outcome measures. Number 1, Vancouver Burn Scar Scale. It measures pigmentation, pliability, thickness, and vascularization. Number 2, Patient and Observer Scar Assessment Scale. It measures pigmentation, vascularity, thickness, relief, pliability, and surface area. Also includes assessment of patient pain, itching, color, stiffness, thickness and relief. Scar management. Silicone. Silicone gel or sheeting can be used as an adjunct to prevent and treat hypertrophic scarring. Pressure garment therapy. Aims of pressure garment therapy are: it reduces scarring by hastening maturation. Pressure decreases blood flow. Local hypoxia of hypervascular scars. And reduction in collagen deposition. Massage. Massage techniques for scar management includes retrograde massage to aid venous return, increase lymphatic drainage, and mobilize fluid. Effleurage to increase circulation. Static pressure to reduce pockets of swelling. Finger and thumb kneading to mobilize the scar and surrounding tissue. Skin rolling to restore mobility to tissue interfaces. Wringing the scar to stretch and promote collagenous remodeling, and frictions to loosen adhesions. The role of the physiotherapist in the rehabilitation of chronic burn patient. Healing process may continue for up to 2 years as scar tissue remodels and matures. Patient may require functional retraining and integration back into the community and activities. Post-burn, aerobic and resistance training. It is proposed that aerobic capacity and muscular strength is diminished by the following factors: prolonged bed rest, hypermetabolism, which may lead to exhaustion, protein catabolism, and loss of lean body mass. Impaired thermoregulation, inhalation injuries, and compromised respiratory function. Exercise prescription. Frequency 3 to 5 times per week. Intensity between 65 to 85%. Predicted heart rate max. Type: treadmill training, whether walking or running. Time. Duration of treatment can be vary. Some studies suggest that it should be 12 weeks, but depending on the condition of patient. Duration of each session should be at least 20 to 40 minutes. Resistance training. Exercise prescription. Frequency 3 times per week. Time. Duration of treatment can be vary. Some studies suggest that it should be 12 weeks, but depending on the condition of patient. Type and intensity. Using free weights or resistive machines. One set of 50–60% of the patient's 3-room week 1, followed by a progression to 70–75% for week 2 to 6 with 4 to 10 repetitions, and 80–85% in week 7 to 12, with 8 to 12 repetitions. Isokinetic training. 10 reps at 150 degrees per second, using 1 to 5 sets for the 1st to 5th session, 6 sets for the 6th to 24th session, and 10 sets from 25th to 36th session, with 3-minute rests between sets. I hope this will be beneficial for you. To watch more such videos, subscribe the YouTube channel, and hit the bell icon.